The content of this podcast has not been evaluated by Health Canada or the FDA. It is educational in nature and should not be taken as medical advice. Always consult a qualified medical professional to see if a diet, lifestyle change, or supplement is right for you. Any supplements mentioned are not intended to diagnose, treat, cure, or prevent any disease. Please note that the opinions of the guests or hosts are their own and may not reflect those of Advanced Orthomolecular Research Incorporated. Welcome to Supplementing Health, a podcast presented by Advanced Orthomolecular Research. We are all about applying evidence-based and effective dietary, lifestyle, and natural health product strategies for your optimal health. In each episode, we will feature very engaging clinicians and experts from the world of functional and naturopathic medicine to help achieve our mission to empower people to live their best lives naturally. Most women have experienced the unpleasant symptoms that come knocking monthly with Aunt Flo. For some women, however, these symptoms are magnified due to serious hormonal imbalances. AOR's Advanced PCOS Relief provides myo-inositol, D-chiroinositol, along with a bioavailable form of folic acid to support healthy ovarian function and improved egg quality. It also helps to normalize the menstrual cycle, balance mood, and aids in regulating metabolic factors. Find balance today with Advanced PCOS Relief, available at your local retailer or online at aor.ca. Hello, welcome to Supplementing Health. I'm very excited to have Dr. Tracy Malone and Dr. Jennifer Fitzgerald joining me today to discuss polycystic ovarian syndrome, or PCOS. Dr. Malone and Dr. Fitzgerald are the co-founders of Conceive Health in Ontario, and their clinic combines conventional and naturopathic medicine to help patients optimize their fertility. Welcome, ladies. Thanks for joining me today.
Yeah, thanks for having us this morning.
So let's start right at the beginning of what is PCOS?
What is PCOS? So I'll just give you a little bit of background of where I'm coming from. I'm a naturopathic doctor, and I've been in practice for about 15 years, and pretty much have exclusively done women's health almost my entire sort of practice career. And now I work in a fertility clinic, a very fertility-focused clinic. And so I see this condition all the time in my practice. And so I think the first thing people need to recognize about PCO, which would be polycystic ovaries, or PCOS, is that it's an endocrine condition, that affects females. And it typically presents early on in menstruation or menarche. And there's, signs and symptoms that you should be able to kind of pick up, even without going to a doctor, that would give you some indication that you might be manifesting PCOS, or polycystic ovarian syndrome. So the first clue is that your period isn't very regular, right? So you would have missed periods, or maybe you didn't get a period at all, when you were a teenager and going through puberty. Maybe you only get one every 3 months. Maybe you get one every 2 months. So the cycle regularity is all over the place. And the reason for that is because there is an irregular ovulatory pattern. So the dominant follicles that looking to ovulate that month either isn't developed or isn't developing on the expected timeline, likely due to hormone disruption. And so then it doesn't ovulate on time. And because of that, you have a longer cycle or no cycle if she doesn't ovulate at all. And then the third criteria would be sort of excessive hair growth, which is termed hirsutism. So this could manifest in so many different ways in patient population. Sometimes I don't see it at all. And sometimes it's quite evident. And so you can have facial hair on your lip, in the sort of, jawline area. You can have increased facial hair down the abdomen and down the midline and around the areola. So those are areas where you may see excessive hair growth. And this, you'll find out later as our discussion goes on, has to do with disruption in estrogen and androgen ratios. So it's the androgens or the testosterone that sort of drives that symptom of hair growth. She may or may not have be overweight or have gained weight, in the last little while, and that will really set off or amplify those other symptoms I just listed. She may experience thinning hair, and she may have acne. So those are the sort of typical criteria that might identify a patient that has PCOS, and maybe what might lead her to go to the doctor first, to start investigation.
Okay, and you said you see this fairly frequently in your practice. So what percentage of women actually are affected by PCOS?
Oh, I would say lots. I would say in my practice, probably so common in my practice, I'm going to say 40%, Jennifer. Would that be fair?
I would say in our practice, yes. In general population, I'd say it's more like probably 10%. In a fertility population, though, you're going to see a much higher incidence of that.
Yeah.
Right?
Yeah. So my patient base are people that are trying to get pregnant. So I guess it would be skewed in my particular demographic, right?
Right. Okay. Yeah, no, that makes sense for sure.
It's incredibly common, I think. And I think it's very commonly missed or undiagnosed. It can go on undiagnosed for a long time. Mm-hmm.
Yeah, on that note, I was going to ask, is there like an age that women are usually diagnosed with PCOS, or can it go undetected for years?
It can go undetected for years for sure, I think. I mean, it is an endocrine disorder. It has some perhaps genetic predisposition sometimes, and then what I would call kind of the epigenetic influence, where our diet and our lifestyle could potentially contribute to or exacerbate our, say, genetic tendencies, right? So in those cases, if somebody lived a really, really, clean lifestyle and ate really well and exercised, they might not display those components of PCOS that might contribute to, say, weight gain as much as somebody that didn't lead that type of a lifestyle. And then that might be displayed differently. So we'll sometimes see kind of like dormant PCOS, where it's being controlled by lifestyle. So in other situations, maybe that woman would have the symptoms of, but because she's controlling it so well, it's not being displayed. Does that make sense?
Yeah, absolutely. That makes sense. Yeah. And then a lot of those symptoms in and of themselves could happen for other reasons as well, right? Like you could miss a period due to stress. So how do you know that those symptoms actually are playing into PCOS versus maybe endometriosis or other potential gynecological issues?
So when you get the patient in the clinic, so first of all, I think that a lot of times women or young women, teenagers, show up at their family doctor's office with either irregular periods or acne. And the first knee jerk to help to ameliorate those two symptoms of irregularity and acne is to put her on birth control. Mm-hmm. And when you put her on birth control, you give her a steady stream of estrogen, and she appears to have a normal cycle. She has a regular menstrual cycle because of the addition and removal of the birth control will make her cycle. And it will often clear up her acne as well. So a lot of those women go totally undetected until they come off the birth control pill, right? As far as diagnosis is concerned. But if they were sent maybe for, an ultrasound, you might see on ultrasound, and this is the difference, between PCO, polycystic ovaries, and PCOS. So you can have polycystic ovaries on ultrasound, which is a morphological characteristic of the ovary, right? So when you look on a transvaginal ultrasound, you'll see that the cc's of the ovaries, or the volume of the ovary, is enlarged typically, usually above 10 cc's, I think it is. Anything above that would be considered enlarged. And then you'll also see that they have a super high follicle count. So by follicles, when you do a transvaginal ultrasound, you can actually see the follicles that are coming up to the plate for development, count them. So if a woman would have more than 12 to 15 on both sides, she would be considered to have polycystic ovaries, despite maybe there's no active cyst there at all. And she may very well have a regular cycle, right? But she has polycystic ovaries on ultrasound, right? For PCOS, the syndrome, she's going to be also carrying along some of those other symptoms that's like the acne, they call it oligo-ovulation, which means it takes a long time for her to ovulate. So she may not ovulate on day 14. She may ovulate on day 20 through 40 kind of thing, depending on how long her cycle is. And that's what causes the disruption in the regularity of the period.
Okay. So outside of fertility issues, how can PCOS or PCO affect a woman's health?
Oh, there's so many ways.
Yeah. So,
Yeah.
I mean, kind of the metabolic fallout of PCOS would include things like insulin resistance. So your, dysregulation with blood sugar and, potentially being hyperglycemic, hypoglycemic, and potentially developing diabetes, right? Type 2 diabetes as a result of that. And then from a metabolic perspective, it also contributes to things like cardiovascular disease, high blood pressure, cholesterol issues, those types of things. So it really does impact their metabolic health quite significantly if it's not controlled.
Yeah. And I would say the worse, in a sense, their metabolic state gets, the more exaggerated the PCO symptoms. So I think one of the cool things that you can always tell we call them Cysters, right? Like CYSTS, like cyst, ovarian cyst, Cysters. You can lose as little as 5% of your body weight, which is usually only 5 to 10 pounds, and totally trigger your ovulatory function again.
Okay, interesting. And are lifestyle changes and hormones kind of the only two ways, like you said, losing weight, but are hormones usually the main way that you treat someone with PCOS? Or are there other treatment options or lifestyle options that help to manage and control those issues?
That's a good
Well,
question.
based on research, actually, the best intervention for PCOS is diet and lifestyle changes. So controlling the insulin resistance basically is the best way to start. So even when they compare things like medication to natural treatments, often, at least especially from a fertility perspective, there's more success with lifestyle intervention than there is with medical.
Yeah, and you have to be specific. So like at the base of it all, PCOS, in my opinion, is a glucose. It is in part a glucose disorder. And, if you consider insulin being a hormone as well, one of the lifestyle factors that I kind of always enforce with my patients is that they want to start weightlifting usually, like unless they're lean PCO. For lean PCOS, or the tag term is called skinny PCO. So these might be, sort of atypical PCO patients versus polycystic ovarian syndrome patients. So these patients have a normal BMI, typically low end, maybe lower end, like 19 or 20 or below. And they will cycle normally. Typically, they will have a regular cycle without any issue, but they can also have issues with egg quality and ovulatory patterning, although they won't pick it up typically unless they go in for an ultrasound, right? Because that's where you end up seeing it morphologically anyway. And treatments are similar, but it is for those patients, it's a lot about meal frequency and making sure they're getting adequate calories and not under consuming. So at the base of it still is a glucose issue, but you would treat them differently from a diet and lifestyle. So instead of saying, I want you to lose 5 to 7 pounds, I want you to gain 5 pounds. And that'll actually improve their hormonal profile and ovulatory regulation. Anyway, I wanted to mention that because I think the lean PCO patient is underdiagnosed and misunderstood often. And so if she's that traditional Rotterdam, the Rotterdam classification is the traditional PCOS patient who has no or long cycles, overweight, acne, hair loss, all of those. She often needs to put on lean muscle mass because the insulin receptors live in the muscle mass, and the better you can sensitize and increase the concentration of her insulin receptors, the faster you're going to help with her sort of PCOS endocrine function as well. Because when your insulin is high, which a lot of women, with PCOS have this insulin resistance picture because they're young. So they may not display full-blown diabetes. Their hemoglobin A1C may be normal. But if you look at the ratios between their fasting glucose and their fasting insulin, oftentimes that number clips up above 3, the ratio, and then that would display that she's indeed insulin resistant. And when you have that accumulated insulin in her system, that interacts with her ovaries to cause the Sequel cells there to produce more testosterone. And then around and round we go, and we have this insulin resistant, high insulin testosterone circle, which causes all of these symptoms. So at the base of it, she needs to, reduce the types of certain types of carbohydrates in her diet. And recall, I said reduce, not eliminate. And then she also needs to, weight lift and get adequate protein so that she has a hope to bring up her muscle mass. I think that's like a real key component of PCOS treatment from a lifestyle perspective. Mm-hmm.
So are those the key components to the PCOS diet? Because you hear, if you search PCOS online or you hear people talking about it, there's what's referred to as the PCOS diet. Is that mostly just reducing your sugars and helping balance that insulin resistance? Or is it more than that?
I think it's a little bit more than that. For sure, I think that's at the base of it. So I usually get my patients to come away from grains and do more plant-based carbohydrates and high proteins. But there is an element in PCO of inflammation. And so certainly those PCO diets out there do target inflammatory function because of the endocrine disruption and the metabolic disruption. Polycystic ovarian patients tend to be prone to inflammation, which is sort of the connectivity as well to the cardiovascular component of the condition. So you'll see them being reduced in dairy, reduced in saturated fat, those types of things as well.
Okay, cool. And so jumping back a little bit to the cysts specifically, what causes them to burst and what happens if they do burst?
Well, a cyst that bursts is usually not necessarily a cyst that's associated with our typical PCOS type patients, right? So a burst or a ruptured ovarian cyst is typically what you're going to refer to as a functional cyst. And those are cysts that are growing in response to estrogen and are creating some other types of issues. You don't typically see that in PCOS patients in terms of the increase in the size and rupturing like that. That would be kind of an atypical thing to see in PCOS.
Mm-hmm. You might see it once in a while, but it wouldn't happen to her every month, maybe.
And it potentially, you might see that in a fertility clinic setting when they've been stimulated with fertility medications. You might see that a bit more often, but I wouldn't expect to see that routinely in a PCOS patient.
Yeah. But when you do, and so occasionally you do, and they're called hemorrhagic cysts, right? When they burst and they hurt, and she will often definitely feel it, and perhaps she might have tenderness or pain prior to or surrounding ovulation. And a lot of times, if it's a significant size cyst, she'll take herself off to the ER thinking she has appendicitis. That's how painful they are. Sometimes they cause spotting. Yeah. But, it's rare. It's rare for it to go on and her have those monthly, as Jennifer said. Usually that we say cysts happen, they come and go. And sometimes we'll catch them on ultrasound. And, you know, these can absolutely be driven by lifestyle as well. So if she's drinking a lot of alcohol and a lot of coffee and things that would inhibit or alter her estrogen metabolism, she might be more likely to develop this, right, if she's prone.
Right. So if your PCOS goes undiagnosed, how does that impact your fertility?
It delays or prevents ovulation. So if a woman is having an irregular menstrual cycle, so say she's ovulating late, so what that tells us clinically is that that particular egg is taking too long to grow, right? So typically we would ovulate a healthy egg by, say, day 14 of a normal menstrual cycle. And so any egg that would be ovulating, say, beyond day 17 or 18, we'd be sort of questioning the quality of that egg, right? It's taking too long to mature, so therefore it's not, getting the right signals. It's potentially a low energy oocyte, something along of that nature. If you see a woman that doesn't cycle for, say, every 3 months, then she's probably not ovulating at all, right? And so in order to conceive, we must ovulate. That is step number one. So that is why it makes it so difficult for PCOS women to become pregnant, is the either the absence or the delay in ovulation. It makes it very difficult for timing. And then when they do ovulate, it's not necessarily a good egg.
Mm-hmm. And so then you have to go on the hunt for, like, what is the hormonal disruption? And so this is where you come into the variances of the PCOS expression or PCO expression. Sometimes it's their insulin's totally whack and it's too high, and you need to go after a metabolic type of treatment plan with them and get them to ovulate regularly. Sometimes their androgen, sometimes their cycles are regular, but their androgens are through the roof, and that can really interfere with the maturation of the egg, right? And so you have to go then and test her, do some testing, right, to really be able to tease out what kind of PCOS does she have.
Okay. And once a woman gets pregnant, if she has PCOS, are there any potential risk factors during pregnancy or any influences that PCOS has?
Well, yep, there's some for sure. So women with PCOS would be more likely to develop gestational diabetes, for one. They have a higher risk of things like preeclampsia or preterm labors, high blood pressure during pregnancy, those types of things, higher than normal birth weight babies, so larger babies.
Yeah, for sure. It feeds all into the glucose disruption, that it's kind of, she's vulnerable to genetically. And I don't mind sharing, like, I'm a PCO patient and I had gestational diabetes for sure in my third pregnancy. So, and had a 10.5 pound baby, and I'm like 100, I'm 130 pounds, so it's tricky condition, and now because that happened, I'm 75% more likely to become a type 2 diabetic in my adult life. Right?
Oh, wow.
And then potentially, if it's uncontrolled during pregnancy, they do see effects on the children, right? So in terms of an increased risk for high cholesterol, diabetes themselves, and adulthood type diabetes, those types of conditions.
That's called like genetic imprinting or epigenetics. And so I also don't mind sharing, I have three children, and in my first two pregnancies, no gestational diabetes. In my third pregnancy, gestational diabetes, but I would say well controlled. Despite that, a 10.5 pound baby, so it's like, macrosomic. They call that a big birth weight baby. And he had a little bit of glucose fluctuations at birth and an ASD defect, which was it's a heart defect. And although things like that run in my family, they contributed to the gestational diabetes. It closed and is totally normal now, but none of my other children manifested it. So I have to think that it would be the environment.
Mother's health definitely influences the development of the baby. on all
Yeah.
fronts, right? Like just like the diet and everything that the mom's taking in that feeds baby's development. So it makes sense that something like this would also play a role in that development to a certain degree, right?
Right. But the good news is that if we control it during pregnancy, that it does lessen those risk factors, right? So that's the key to,
That's
preconception
right.
and controlling it, diagnosing PCOS early, getting it under control prior to pregnancy is ideal. But even if not, working on it and working with a healthcare provider during pregnancy to control those values as well.
Yeah, we would always encourage the lifestyle technique, first, and I would say adjunctively in our clinic. We work in an IVF clinic, so a lot of times, the first knee-jerk reaction medication for PCOS is metformin, right? And so metformin shows that it has efficacy on ovulatory regulation, and it impacts the insulin and glucose sensitivity of the patient, and it helps her lose weight. So those two things before you get pregnant are really important, because we know that those patients are then going to be vulnerable during pregnancy to gestational diabetes. So I always kind of say, do it now so you don't have to do it later.
Right. Another supplement I've heard commonly used for PCOS patients is inositol. Do you guys use that in your clinic, and what does it do for PCOS?
Sure.
We use a great deal of inositol in our practice, including PCOS. Yeah. So it is like a sensitizer to the insulin, essentially. It helps the body be more sensitive to it and more sensitive to the glucose. So it helps it utilize both insulin and glucose better. And it has a regulatory effect on some of the hormones as well. So we mentioned things like certain androgens like testosterone during the conversation. So not only can it lower things like insulin, but things like testosterone if it's elevated, or other androgens as well. And it has a positive effect on lipids as well in some of the research. So it shows an effect on, say, LDL, triglyceride ratios and levels, and help normalizing those. So it does hit a lot of the different angles.
It has a good impact on mood too. So some people use it for mood, and that's something I think that should really be recognized in a PCO or a PCOS patient. She's prone to anxiety and depression. By controlling some of the hormones and normalizing that, normalizing the glucose sensitivity, she'll notice a reduction in the anxiety and low mood. But inositol definitely has an effect on the mood as well. I've also read papers about inositol specifically to egg quality. So sometimes I'll give that patient, an egg quality patient, inositol, because research demonstrates that the higher the level of inositol inside the follicle and the follicular fluid, the better the quality of the egg.
And androgens often are thought of having a big impact on sex drive and libido in general. So when you come across PCOS patients, do you find their libido is affected, and does treatment help or hinder that in any way?
It's a good question.
Definitely. So, often, libido is multifactorial for sure when it comes to hormones and endocrine system. So androgens are one component of it. So we might hear if we have like low DHEA or low testosterone, you might have low libido. But it doesn't go the other way necessarily, where if you had high testosterone and high DHEA, you might have high libido. We might still see a very low libido in those patients because their estrogen is also so low, right?
Yeah.
So typically, yes, when you start correcting and normalizing the hormones, you do see a return of the libido.
Yeah, that's good point to make. I think more specifically when you get her ovulating, she notices a pickup in her libido.
And fertility obviously is a two-person job to actually procreate. So is there a version of like a male style PCOS? Obviously they don't have PCOS because they don't have ovaries, but they do have their testes and they function in a somewhat similar way. So do they have something that's similar that could affect them?
Not really in the same kind of way. So men, you're more likely to see, say, low hormones, like more of like an andropause type situation, or it's usually structural or a varicocele or something like that.
Yeah.
So not, I mean, I don't think, I mean, you can see a cyst in a testicle here and there, but it would be pretty uncommon.
Yeah, I think more specifically, like he would probably be diagnosed with diabetes or pre-diabetes,
Yeah.
kind of thing. And then you'll see augmentation in the semen analysis. Motility specifically counts sometimes.
Okay. And we've been learning more about metabolic syndrome as well. Is there ever misdiagnosis of PCOS as MED-S or vice versa that then has to be corrected, or can they be misdiagnosed and still end up addressing the root issue?
I think if you address metabolic syndrome, you're going to be addressing a lot. I guess it depends on how you're treating it. Like if she's treating it with pharmacy, it's not going to help her PCOS. I mean, if she's got metabolic syndrome and they put her on Lipitor and a high blood pressure medication, it's not going to make her PCOS any better.
Right.
But if she, if they treat her metabolic syndrome with, nutrition and lifestyle, and she corrects her body composition, then that's going to influence her PCOS.
What would be some of your key tips for someone who's just trying to figure out if they have PCOS and wants to kind of manage it until they get a diagnosis?
If they have yet to have a diagnosis and how to manage it in the meantime. So I would start with diet and exercise. So moving your body in terms of the exercise and start building lean muscle mass. So lifting weights, Tracy sort of mentioned earlier, is a really great place to start on that. But moving in general, so you're trying to increase lean muscle mass in order to increase the number of insulin receptors in your body is the bottom line there. So any movement is better than no movement. And then starting to eat what we would call a low glycemic diet. So that's removing a lot of the simple carbohydrates out of our diet. And so we would normally go as far to say is remove a lot of the grains or most or all grains from your diet to start. That will very quickly make somebody's diet low glycemic because wheat breaks down into sugar, not because it has gluten in it. You're trying to eliminate one of the main kind of source of sugar, essentially, and in the most direct route of. And so we don't want to take fruits and vegetables away because they have so many other health benefits to them. And that's where our antioxidants lie and all of the good anti-inflammatory properties. So we want to remove grains, which, tend to be more inflammatory and cause more of a blood sugar index spike. So we remove those things, then we focus on our good carbs and our healthy proteins and healthy fats. And that is really the foundation, I think, of PCOS care.
Is there something or specific tests that a woman should ask for if they suspect that maybe they have PCOS and they're talking to their family physician and want to uncover that?
Yeah, the most obvious test, I think, is an ultrasound, right? That'll tell you fairly quickly, because you can see the characteristics on the ultrasound. And then, you can also, there's hormonal tests that you can get done. So for example, AMH, anti-Müllerian hormone, is a test that you can have done. In the clinic, we use it it's kind of known as the ovarian reserve test, but in PCO patients or polycystic ovarian patients, it will be elevated for age. And then you could test androgens, right? So this blanket term of androgens, so testosterone, free and total testosterone, DHEA, androstenedione. Sometimes I test dihydrotestosterone, but to start with the basics to see if any or all of those are elevated. Usually it's one, and the rest of them are just high normal.
Insulin and blood sugar screen I would look at initially as well.
Yeah, the HOMA-IR,
Yeah, cholesterol panel as well to look at their cholesterol values. And then also in terms of the hormones, we work in a fertility clinic, so often you would have their day 3 hormone profile available to you, and you might see a skewed ratio in their LH-FSH ratios on their day 3. So I'm always kind of looking for that higher level of LH on day 3 than the FSH, and that will kind of steer me into looking a little bit further for that particular person.
Awesome. Well, thank you so much for sharing all your knowledge on this topic. I think it's something that, like you said, affects a lot of women and maybe isn't as discussed as it should be. So I really appreciate you two taking the time to chat with me today. If our listeners want to work with either of you, what's the best way for them to get a hold of you?
Our website, probably conceivehealth.com, and they can book and find our bios and all kinds of information just directly from there.
Fantastic.
Yeah. Okay, great. Well, thanks for your time and for the opportunity today, Sarah.
Yeah, thank you both. I really appreciate it. Thank you for listening to Supplementing Health. For more information about our guests, past shows, and future topics, please visit aor.ca/podcast or aor.us/podcast. Do you have a topic you want us to cover? We invite you to engage with us on social media to request a future topic or email us at marketing